You might not think much about vitamin B12 on a daily basis, but for seniors, it's one of the most crucial nutrients for maintaining health and vitality. This vitamin plays a starring role in keeping your nervous system functioning smoothly, your blood cells healthy, and your mind sharp. Yet, as you age, getting enough B12 becomes trickier, and the consequences of deficiency can be serious. Let's start with the basics. What does B12 actually do? First, it's essential for nerve health. B12 helps maintain the protective coating around your nerves, called the myelin sheath. Without enough of it, nerve signals slow down or misfire, leading to tingling, numbness, or even balance problems. Over time, severe deficiency can mimic neurological disorders like dementia or neuropathy. Second, B12 is a key player in red blood cell production. When levels drop too low, your body can't make enough healthy red blood cells, leading to megaloblastic anemia, a condition where your blood cells are oversized and inefficient at carrying oxygen. The result? Fatigue, weakness, and shortness of breath, even with mild activity. Finally, B12 supports brain function. Research links low B12 to memory lapses, brain fog, and even an increased risk of cognitive decline. Some studies suggest that correcting a deficiency might slow the progression of conditions like Alzheimer's, though more research is needed. But here's the catch: your body doesn't make B12 naturally. You must get it from food or supplements, and as you age, absorbing it becomes harder. Stomach acid declines, and the protein needed to absorb B12, called intrinsic factor, may dwindle. That's why even if you eat plenty of B12-rich foods, you might still fall short. So, if you're feeling unusually tired, forgetful, or just off, B12 could be a silent culprit. The good news? Once detected, deficiency is treatable. But first, you need to understand how aging changes the game, which brings us to the next critical piece of the puzzle: absorption challenges. As you age, your body becomes less efficient at absorbing vitamin B12, not because you need it any less, but because the mechanisms that extract it from food start to break down. Understanding why this happens is key to ensuring you get enough of this vital nutrient. The stomach acid factor when you eat foods containing B12, like meat, fish, or dairy, the vitamin is tightly bound to proteins. Your stomach acid is supposed to break these bonds, freeing B12 so it can be absorbed later in the small intestine. But here's the problem: stomach acid production declines with age. By the time you're in your 60s or 70s, you may have significantly less acid than you did in your younger years. This condition, called hypochlorhydria, means that even if you're eating plenty of B12-rich foods, much of it may pass right through your system unused. Some estimates suggest that 10–30% of seniors don't absorb B12 from food efficiently because of this issue. The intrinsic factor. Problem: once B12 is freed from food, it needs to bind with a protein called intrinsic factor, which is produced in your stomach. This complex then travels to the lower small intestine, where absorption happens. But two things can go wrong. Autoimmune atrophic gastritis. Your immune system mistakenly attacks the stomach cells that make intrinsic factor. Without it, B12 can't be absorbed, leading to pernicious anemia, a severe form of deficiency. Natural decline. Even without an autoimmune condition, intrinsic factor production tends to decrease with age, making absorption less reliable. Other roadblocks to absorption medications: proton pump inhibitors, PPIs like omeprazole, and H2 blockers like famotidine, reduce stomach acid, worsening B12 absorption. Metformin, a common diabetes drug, can also interfere. Digestive disorders, conditions like Crohn's disease, celiac disease, or even past stomach surgeries can damage the areas where B12 is absorbed. Bacterial overgrowth. Some seniors develop excess bacteria in the small intestine, which can steal B12 before your body can use it. What does this mean for you? If you're relying solely on dietary B12, you might not be getting enough, even if your diet is excellent. That's why many experts recommend that all adults over 50 get most of their B12 from fortified foods or supplements, which don't require stomach acid for absorption. But not all supplements are created equal. Some forms of B12 are better suited for seniors than others, which brings us to the next critical question. Which type of B12 should you be taking? Not all vitamin B12 supplements work the same way in your body, especially as you age. Walk into any pharmacy or health food store, and you'll find multiple forms of B12 on the shelf: methylcobalamin, cyanocobalamin, hydroxycobalamin, and even adenosylcobalamin. Which one should you choose? Let's break down the science so you can make an informed decision. Cyanocobalamin, the most common, but not always the best. This is the synthetic form of B12 found in most multivitamins and fortified foods. Pros. Highly stable and long shelf life, inexpensive and widely available, converts into active B12 in the body. Cons. Contains a cyanide molecule, minimal amount, but some prefer to avoid it, requires conversion in the liver, which may be less efficient for seniors, not ideal for people with kidney issues, best for budget-conscious seniors without severe deficiency or absorption problems. Methylcobalamin, the active, bioavailable form. This is the natural, ready-to-use form of B12 that your body can utilize immediately. No conversion needed. Pros. Directly supports nerve and brain function. Better for people with methylation issues, common in aging. No cyanide. Component cons. Slightly more expensive. Less stable in some formulations. Best for seniors with nerve-related symptoms, tingling, numbness, memory issues, or known methylation disorders like MTHFR gene mutations. Hydroxycobalamin, the long-lasting option. This natural form binds well to proteins in your blood, releasing B12 slowly over time. Pros. Stays in your system. Longer than other forms used in B12 injections, common for severe deficiency, helps detoxify cyanide, beneficial for smokers. Cons. Not as readily available in oral supplements, may still need conversion to active forms, best for seniors with severe deficiency or those who prefer injections. Adenosylcobalamin, the energy booster. This active form supports mitochondrial function, your cell's energy factories. Pros. Critical for energy production. Works synergistically with methylcobalamin. Cons. Harder to find in supplements, usually combined with methylcobalamin. Best for seniors with chronic fatigue or muscle weakness. Which one should you take?
For general maintenance, a high-quality multivitamin with methylcobalamin or hydroxycobalamin. For nerve-brain health, methylcobalamin, sublingual or liquid. For severe deficiency, hydroxycobalamin injections, under a doctor's supervision. But even the best form won't help if the dosage is wrong. So, how much B12 do you actually need? You now know which forms of B12 work best for seniors. But how much should you actually be taking? The answer isn't one size fits all. While B12 is water-soluble, meaning excess amounts usually get flushed out in urine, taking too little won't correct a deficiency, and taking too much might still cause unintended effects. Let's navigate the dosing maze together. The baseline, official recommendations. The National Institutes of Health, NIH, recommends 4 mcg per day for healthy adults, mcg per day for pregnant women, mcg per day for breastfeeding women. But here's the catch. These numbers assume perfect absorption, which many seniors simply don't have. Why seniors often need more? Due to age-related absorption issues, discussed in Section 2, most experts suggest 100 mcg daily from oral supplements, even without deficiency, $1,000 to $2,000 mcg daily if You have diagnosed deficiency or absorption problems. Wait, that's 100 times the RDA in some cases. How can that be safe? The absorption paradox, a fascinating quirk of B12. Only about 1% of oral B12 gets absorbed passively, without intrinsic factor, stomach acid. So, a 1000 mcg dose delivers roughly 10 mcg absorbed, enough to compensate for poor absorption. This explains why high-dose oral B12, like 1000 mcg methylcobalamin, is often recommended for seniors instead of injections. When to consider injections, while high oral doses work for many, injections, typically hydroxycobalamin or cyanocobalamin, may be needed if you have pernicious anemia, no intrinsic factor, severe neurological symptoms exist, numbness, balance issues. Oral supplements aren't raising blood levels, a common protocol. Loading. Phase, 1 mg injected daily for 1 week maintenance, 1 mg monthly, or high-dose oral upper limits. Can you overdo it? No tolerable upper intake level, UL, exists for B12 because toxicity is extremely rare. However, some studies note acne-like rash in high doses, likely from bacterial skin changes, mild diarrhea in sensitive individuals, false low potassium levels, rare but can occur with deficiency treatment. More importantly, excess B12 can mask folate deficiency, so balance is key. Personalizing your dose. Your ideal dosage depends on current blood levels, serum B12, MMA, absorption capacity, stomach issues, PPIs, symptoms, fatigue versus nerve damage. Example, scenarios. I feel fine, just maintaining 100-500 mcg methylcobalamin daily. I'm on PPIs and feel tired, 1000 mcg sublingual daily. Diagnosed deficiency with tingling hands. Injections, plus 1000 mcg oral. But how do you know if you're deficient in the first place? The symptoms can be sneaky. Fatigue. Memory lapses. That lingering, just not quite right feeling. Many seniors dismiss these as inevitable parts of aging, but what if your body is actually sending you a distress signal about vitamin B12? The symptoms of deficiency are often subtle, easily mistaken for normal aging, yet they can progress to irreversible nerve damage if ignored. Let's decode these warning signs before it's too late. Early stage, the silent alarm bells. B12 deficiency creeps in slowly. At first, you might notice unusual fatigue, despite adequate sleep, mild dizziness when standing up, slight tingling in hands, feet, pins and needles, occasional word-finding trouble. It's on the tip of my tongue. These vague symptoms are why deficiency often goes undiagnosed for years. Many doctors check iron or thyroid first, while B12 gets overlooked. Moderate deficiency, the body begins to break down. As stores deplete further, more alarming signs emerge. Anemia, symptoms pale, or yellowish skin, shortness of breath after minor exertion, heart palpitations. Neurological red flags, persistent numbness, tingling, especially symmetrically in hands, feet. Trouble walking straight, loss of proprioception. Sharp, burning pains in extremities, depression, or irritability. B12 is needed for serotonin, dopamine production. Severe deficiency, when damage becomes permanent. Left untreated, deficiency can cause psychiatric symptoms, paranoia, hallucinations. Severe, neuropathy, inability to walk without assistance. Dementia-like cognitive decline, reversible if caught early. Tragically, by this stage, some nerve damage may be irreversible. That's why recognizing early signs is crucial. The great mimicker, conditions, B12 deficiency, masquerades as early Alzheimer's, memory fog, normal aging, weakness, fatigue, arthritis, balance problems leading to falls, depression, low mood, apathy. Who's most at risk? Check these boxes. Over 60 years old. Take acid reducers, PPIs like Nexium,
H2 blockers like Pepsid. Vegan, vegetarian, no animal products. Had stomach surgery, e.g., gastric bypass. Diagnosed with autoimmune disorders, thyroid issues, diabetes. If any apply, even without obvious symptoms, you should be tested. Why blood tests? Can mislead. Here's a scary truth. Standard B12 blood tests often miss early deficiency. Why? Normal lab ranges are too broad, 200 to 900 pg/ml. Some people have symptoms at 300 pg/ml while others don't until under 150 mmA. Methylmalonic acid and homocysteine tests are more sensitive. Bottom line? Symptoms plus risk factors, lab numbers. Alone. Now that you know what to look for, how do you confirm whether it's truly B12 deficiency and not something else? You've recognized the symptoms. You've assessed your risk factors. Now comes the critical step, confirming whether you truly have a B12 deficiency. But here's where many seniors hit a roadblock. Standard blood tests can be misleading, and some doctors dismiss early warning signs. Let's arm you with the knowledge to get an accurate diagnosis before deficiency causes permanent harm. The problem with standard B12 blood tests. When you ask your doctor to check your B12 levels, they'll likely order a serum B12 test. While this is a good starting point, it has serious limitations. Normal ranges are too broad, typically 200, 900 pg/ml. Many experience symptoms at low normal levels, 300, 400 pg/ml. Falsely elevated readings can occur in liver disease or certain blood disorders. More reliable tests. Your doctor should order methylmalonic acid, MMA. What it measures: metabolic byproduct that accumulates when B12 is low. Why it's better: rises before serum. B12 drops significantly, optimal level. 370 nmol/L. Higher suggests deficiency. Homocysteine. What? It measures amino acid that increases with B12 or folate deficiency. Why it matters. Levels 12 mmol/L may indicate B12 issues. Bonus. Also, screens for heart disease risk, tingling, active B12. What it measures: only the B12 actually available. For your cells to use, best for early detection, shows problems before serum B12 does. When to push for further testing, you should insist on MMA homocysteine testing. If your serum B12 is 400 pg/ml with symptoms, you're on PPIs or metformin long-term. You've had gastric surgery, your symptoms improve with B12 supplements, but blood levels appear normal. The B12 trial approach: when tests are inconclusive, but symptoms suggest deficiency, take high-dose B12, 1000 mcg methylcobalamin daily. Track symptom changes over 1 to 2 months. If improvements occur, you likely had a deficiency. Common diagnostic pitfalls to avoid: stopping at a normal serum B12 result when symptoms persist, not testing MMA homocysteine in high-risk patients, assuming neurological symptoms must come with anemia. They often don't. Overlooking deficiency in patients with adequate dietary intake. Pre-test preparation for accurate results. Fast for 8 to 12 hours before testing. Avoid B12 supplements for 24 hours unless directed otherwise. Get tested in the morning when possible, interpreting your results. Use this quick guide. Serum B12, 200 pg/ml. Definite deficiency. Serum B12, 200, 300, sure borderline, need MMA homocysteine. Serum B12, 300, 500, sure possibly insufficient if symptoms exist. Elevated MMA, 370. High functional deficiency regardless of B12 level. Now that you understand testing, let's explore the most effective ways to replenish your B12, whether through diet, supplements, or other methods. You've confirmed your B12 deficiency, or perhaps you're wisely being proactive about prevention. Now comes the practical question: What's the most effective way to get this crucial nutrient into your system? With absorption challenges that come with aging, swallowing a standard vitamin pill might not cut it. Let's examine all your options, from under-the-tongue tablets to prescription injections, so you can choose the right delivery method for your needs. Oral tablets. Convenient but tricky. The most common form, but problematic for many seniors. Standard. Swallowable tablets. Only about 1% absorbed if you have low stomach acid. Chewable versions. Slightly better absorption. Saliva helps break them down. Typical doses: 500, 1000 mcg daily to compensate for poor absorption. Best for those with mild deficiency, or for maintenance after correcting deficiency with stronger methods. 2. Sublingual. B12. Bypassing the gut. These dissolve under your tongue, entering the bloodstream directly. Absorption advantage. Doesn't rely on stomach acid or intrinsic factor forms available. Methylcobalamin, most common. Hydroxycobalamin dosing. Typically 1000 to 5000 mcg. 1 to 3 times weekly. Pro tip: let it dissolve completely. No eating, drinking for 5 minutes after. 3. B12 sprays and liquids, an often overlooked option with excellent absorption. How they work: absorbed through oral mucosa, like sublingual. Benefits: easy for those who dislike pills. Fast-acting. Dose range: 500 3000 mcg per spray, serving ideal. 4. Seniors with swallowing difficulties or those who want faster results than pills. 4. Prescription injections. The heavy artillery, when oral methods aren't enough. Types: cyanocobalamin, most common. Hydroxycobalamin, frequency: weekly at first, then monthly maintenance absorption. 100% direct into bloodstream. Who needs them? Severe. Deficiency with neurological symptoms, pernicious anemia patients, those who don't respond to high-dose oral B12. Nasal gels, less common but effective. Prescription-only option. How used: applied weekly inside nostrils absorption. Through nasal membranes advantage. Good for those who can't do injections. Fortified foods, helpful but rarely enough. While helpful, these usually can't correct deficiency. Common sources: nutritional yeast, fortified cereals, plant milks. Typical amounts: 1 to 6 mcg per serving. Reality check: you'd need to eat 10+ servings daily to match supplement doses, choosing your best option. Consider this decision tree. Severe symptoms? Start with injections. Moderate deficiency? Sublingual or liquid, 1000 2000 mcg daily. Maintenance only? Chewable or standard tablets, 500 1000 mcg. Hate needles but need strong dose? Ask doctor about nasal gel cost comparison pills. $5 $20 month sublingual, $10 $30 month. Injections, $15 $50 month with insurance. Nasal gel, $100+ month, insurance dependent. Remember, the most expensive option isn't always the most effective. Absorption matters most. Now that you're equipped with this knowledge, we need to address a critical but often overlooked issue: how your other medications might be sabotaging your B12 levels. You could be taking the best B12 supplements available, but if you're on certain common medications, you might be flushing those precious nutrients right down the drain without realizing it. Many seniors are unknowingly caught in this silent nutrient depletion trap. Let's uncover which drugs are the biggest offenders and how to protect your B12 levels while maintaining your necessary treatments. Acid-reducing medications, the B12. Blockers, proton pump inhibitors, PPIs. Omeprazole, esomeprazole, pantoprazole, H2. Blockers, famotidine, ranitidine, how they interfere. Reduced stomach acid needed to liberate B12 from food. Long-term use can decrease absorption by up to 65%. Solution: switch to sublingual liquid B12 forms. Consider periodic B12 injections. Discuss lower dose or intermittent PPI use with your doctor. Metformin, the diabetes drug dilemma, used for type 2. Diabetes impact reduces B12 absorption in the ileum. 30% of long-term users develop deficiency risk increases with higher doses and prolonged use protective measures. Annual B12 testing for all metformin. Users' prophylactic 1000 mcg daily sublingual B12 calcium supplements may help counteract the effect. 3. Diuretics, the silent depleters common types, furosemide, hydrochlorothiazide unexpected effect. Increase urinary excretion of B12 may lower serum levels by 15 to 20%. Management, monitor levels more frequently, increase dietary B12 intake, consider slightly higher supplement doses. 4. Birth control pills, a concern for younger seniors. Relevance, for women who took oral contraceptives for years, long-term impact may have depleted B12 stores over decades, can contribute to deficiency emerging later in life. Action. Be extra vigilant about testing. Consider higher maintenance doses. 5. Anti-seizure medications, common culprits, phenytoin, primidone mechanism, interfere with B12 absorption, may increase breakdown of B12 in the liver. Strategy. Regular monitoring essential. Higher supplement doses often needed. Alcohol, the forgotten drug. Chronic. Effects. Damages stomach lining. Reduced intrinsic factor impairs liver storage of B12. Recommendation. Limit alcohol intake. Increase B12 supplementation if drinking regularly. The medication B12 balancing act. Practical steps. If you're on these medications, don't stop prescribed drugs without medical advice. Add proactive B12 supplementation. Get tested annually. Serum B12 plus MMA. Time your doses wisely. Take B12 at different times than PPIs. When to suspect medication-induced deficiency. Be alert if you develop new fatigue while on these drugs, neuropathy symptoms, cognitive changes after starting medication. Remember, many doctors don't routinely check for these interactions. You must be your own advocate. Now that you understand these hidden medication risks, let's put all the pieces together into a practical, long-term management plan tailored for seniors. You've learned about B12 forms, dosages, testing, and medication interactions. Now let's weave all this knowledge into a sustainable, personalized plan that keeps your levels optimal for years to come. This isn't just about correcting deficiency. It's about designing a lifestyle that maintains your nerve health, cognitive function, and vitality as you age. Here's your blueprint for lifelong B12 sufficiency. Your baseline maintenance plan for most seniors without deficiency. Supplement 500-1000 mcg methylcobalamin or hydroxycobalamin daily, sublingual or liquid. Diet. Include at least 2 to 3 B12 rich meals weekly: clams, salmon, eggs. Testing. Serum B12 plus MMA every 2 to 3 years. Enhanced protocol if on interfering medications. Supplement 1000 mcg sublingual daily. Testing. Annual blood work B12 MMA CBC. Consider quarterly self-assessment of symptoms. The supplementation. Sweet spot timing matters. Morning doses may be better absorbed. Avoid taking with PPIs, acid reducers, space by 2 to 3 hours. Sublingual forms work best before breakfast. Cycling strategy for better absorption. Weeks on, 1 week off. Allows receptors to reset or alternate higher-lower dose days. Dietary synergy boosters pair your B12 with these absorption enhancers. Vitamin B complex, especially folate, B9, omega-3s, support nerve cell membranes. Potassium-rich foods, bananas, spinach, aids utilization. Limit these absorption blockers. Excessive. Alcohol, hot coffee, tea with meals reduces B12 absorption. The monitoring schedule that prevents relapse year 1 after deficiency correction. Blood tests every 3 to 6 months. Symptom journal monthly. Maintenance phase. Annual comprehensive testing. B12, MMA, homocysteine. Immediate testing if symptoms reappear. When to adjust your approach signs, your plan needs tweaking. Symptoms return despite supplementation, unexplained weight loss or digestive changes. New medications added that may interfere. Possible escalations. Increased dose frequency, twice daily. Switch to injections temporarily add digestive enzymes or betaine HCl6. Travel and illness considerations, special situations requiring attention. Hospital stays. Request B12 monitoring, critical illness depletes stores. Food poisoning, GI bugs. Temporary malabsorption may require dose boost international travel. Pack extra supplements, availability varies. The cost-effective approach, smart spending on supplements. Bulk purchases of quality brands, split higher dose tablets if not time-released. Compare pharmacy versus online prices. Insurance tips. Get MMA testing covered by emphasizing neurological symptoms appeal. If injections are denied, provide deficiency documentation. Family awareness. Why loved ones should be informed. Deficiency often runs in families. They can spot early symptoms. You might miss shared meals, can be B12 fortified. Your consistent, informed approach will pay dividends in maintained independence and quality of life. Now, let's conclude with final thoughts and encouragement to take what you've learned and turn it into action. Over these past sections, we've journeyed through the critical importance of vitamin B12 for seniors, from recognizing subtle deficiency, signs to navigating complex absorption challenges and medication interactions. You now hold evidence-based knowledge that many doctors don't routinely share. But knowledge alone isn't power. Applied knowledge is power. Here's how to transform what you've learned into lasting protection for your health. Key takeaways. To remember, deficiency is preventable, even with aging's absorption challenges. Neurological damage can be permanent. Early action is crucial. Standard blood tests often miss problems. Demand, MMA, homocysteine testing, forms matter. Methylcobalamin and hydroxycobalamin outperform cyanocobalamin medications. Steal B12. Proactive supplementation counters this. Your immediate next step: schedule testing. If you have symptoms or risk factors, choose your supplement strategy. Sublingual injections. Mark your calendar for 3-month and 1-year follow-ups. Share this knowledge with friends and family over 50. Stay informed as research evolves. New B12 discoveries emerge regularly. To stay updated, bookmark NIH's Office of Dietary Supplements. Page follow peer-reviewed journals like the American Journal of Clinical Nutrition. Your health span is precious. With consistent B12 care, you're not just adding years to your life, you're adding life to your years. Here's to your vibrant next chapter. Subscribe now for more science-backed senior health strategies. Every new subscriber helps us create content that keeps you informed and empowered. Click the button below. Your future self will thank you.